Okay, well, welcome tonight. I'm Ali Sullivan. I'm an education coordinator at the Primary Health Network, and I'd like to welcome you tonight to the Voluntary Assisted Dying information session. I'd like to begin by acknowledging the traditional owners of the land on which we meet tonight. I'm in Dubbo on Wiradjuri land, and I'd like to pay respect to elders past, present, and emerging. I welcome Aboriginal and Torres Strait Islander people to the webinar tonight, and I welcome everybody tonight. So just a little bit of housekeeping. We've got everyone's on mute, so just questions will go in the chat or the Q&A, and we'll monitor that throughout the session. We'll either answer through the chat, Jade and Mark will do that, or we can stop and Catherine and Warren will be able to address some. We are recording the session. At the end, there will be an evaluation, which is a QR code. If you don't mind scanning that and filling that in, it'd be most appreciated. And thanks again for joining us tonight. So presenters tonight, Dr. Catherine Stewart, and Catherine is a GP and state service with the Western New South Wales LHD VAD practitioner. We have Dr. Warren Keeley-Bateman. He's a psychiatrist with the Western New South Wales LHD and VAD practitioner. Joining the presenters, we also have Professor Mark Arnold, VAD practitioner, rheumatologist and CMO with the Western New South Wales LHD, and Jade O'Brien, the VAD NAV service manager with the Western New South Wales LHD. And I'd like to thank them very much for doing the session tonight. I'm going to ask Catherine now to take over. She'll share the slides from her end. Thank you, Catherine.
Thank you, Ali. I'll just bring mine up. And I'd certainly like to echo that acknowledgement of country that Ali gave us, and recognise the traditional custodians of the lands on which we work and play. As we said, we're going to talk tonight about voluntary assisted dying, a little bit about what's been happening so far, what sort of your involvement can be, and sort of some patient experiences and I guess a few challenges that we have faced. I've been incredibly privileged to work since July last year on the implementation and education, and since November 28, when voluntary assisted dying became legal in New South Wales, I've worked as a VAD practitioner both in Western New South Wales, and we have a fantastic, what we call an access service that travels throughout New South Wales just to make sure that everyone can have access to this.
Catherine, sorry, I'm not sure if you're sharing.
You can't see my slides?
No, I think mine is still there. Just new share and then share again. It should be in blue.
Share.
Ah, that's it. Oh, beautiful. Thank you.
Yep.
Okay.
And I'll just pop it into slideshow. There we go. I think it's important when we're talking about voluntary assisted dying and any end-of-life options, they are very complex. Lots of people have got their own personal views that would come from their own personal experience or their own personal beliefs, and they're very important to them. And certainly we consider that respecting all those views is extremely important. When we look at our service, very much it's a patient-centred care. We certainly work with patient and family. We very much respect the patient's right to have the death that they want to. And one thing that I think we've really come to realise with time, that it's really important that we're not adding any burden or distress to people at the end of their life. So quite recently, and you may have seen media reports of this, there's been a release of a report that's covering nationwide and New Zealand sort of VAD statistics. All states now have VAD in action. ACT has passed legislation and they'll start at the end of next year, so that only leaves Northern Territory. It's interesting though, all states have similar processes but with slight differences. Victoria has had voluntary assisted dying for about 5 years now. And so we often hear a lot about what goes on in Victoria, and we then think that that's what applies here. And there are some slight differences, and I'll try and highlight that as we go. So just a little bit on this report. I do confess, you can see there that I stole this from the media, from 9 News, because I thought it was just such a nice graphic. The things that I find very interesting is that about 56% were male, and we're probably finding that in the state as well, that about 72% had cancer as their primary diagnosis. The other diagnoses that we're seeing would be neurodegenerative conditions, followed by respiratory, and then the other ones, there's a small number of people with cardiovascular, renal, and then very rarely something else. The vast majority of people have accessed palliative care. And it's just really important that we remember that we're not an either or. And very much in Western New South Wales, we work very closely with the palliative care team. And there are, a lot that they provide that we don't. If you look at the graphic there in the top left-hand corner, which talks about the 2 ways that someone can have voluntary assisted dying, either self-administered or practitioner, it's about even throughout the country. What we would say in New South Wales, and certainly our experience, is we're probably more 70% practitioner administration. And I think there's a couple of reasons for that. One is in some states, you must have oral unless you are not able to due to swallowing difficulties. And the other thing I think is access. Some places, people just realise that it's much easier if they can have medication and control themselves. This is something I think we're all a bit aware and have heard over time, that most people actually have a preference to die at home, and most people end up dying, in hospital or in an aged care facility. So if you look at that, then in the general population, about 50% of people are dying in a hospital. And that comes down when we look at voluntary assisted dying, and we find that a lot of people, it's really important to them to be in their home environment, and that's something that we can do. New South Wales has only put out its 3-month report on their statistics, but again, I thought it was just worth highlighting a couple of things. Similar proportion of male. As I said, that higher proportion of people having the IV administration. But the statistic that really stood out for me is that 65% of people are regional. And that means they call that outside Greater Sydney. So we're not sure why yet. We're not sure if that will continue as we release more statistics, but I think it's something that's going to have to be looked at in more detail of why that is. And we certainly hope that it's not because of a lack of access to other services, but if it is, then hopefully that provides support for getting more palliative care, etc. And then the other thing is that 2.5% of people were of an Aboriginal background, and we've certainly had at least one person in our service who was. For those of you who don't know, we've presented a few times on this, and some people are starting to get familiar with it. For others, this might be the first time that you've really tuned in to a talk on VAD. But this is the process, and it's quite complicated that a family or a person going through and wanting voluntary assisted dying has to go through. And if we're just stepping through the process, it would take 2 to 3 weeks from beginning to the end. If someone was really wishing to access voluntary assisted dying much quicker, realistically, a week would be the quickest. So what happens is a patient makes a first request to a doctor, and then we get a coordinating practitioner who must be someone who's done their voluntary assisted dying training, and I'll talk more about that. And what we will do is a first assessment to check if someone's eligible, and again, I'll talk a little bit more about that, what that involves. Then a second independent doctor will come in and does a consulting assessment. So 2 very similar assessments going against all the criteria, and they don't necessarily agree. In most cases we do, but you do need those 2 separate. The person then has to fill out a written declaration in front of 2 witnesses, and we usually then, after they've done that, come back for a 3rd visit, and that visit is usually done by this first person, the coordinating practitioner. So they come back, they check that the person still wants to go ahead with the process, they make a final request, and that's at that point that they make a decision about how they'd like to have medication. All of that information, we have an obligation to complete forms in an online portal, and all that information goes to a board. So there's a voluntary assisted dying board who sit in Sydney and meet twice a week, and there's 5 members of that board consisting of 2 doctors, 2 lawyers, and a 5th community member. They ensure that all the paperwork is correct and that they agree with the decision, and then they give authorisation that someone can access voluntary assisted dying. That coordinating practitioner then gets notification of that. They write a prescription, and then the prescription goes to a pharmacy that's based down in North Shore Hospital. So all the medication comes from that pharmacy. And that's been, at times, a little bit of a challenge for us because of where we are, but we've worked quite hard on that, and we've had enormous support from some of our hospital pharmacies to allow us to store medication with them so that we can get it up and just have it here a sort of week or 2 in advance if a patient is declining but not quite sure of their wishes. If the person is wanting to take the medication themselves, pharmacists from North Shore actually bring it out to their home and leave it with them. And then they have a right to take it at their home, in a nursing home, in their home, in the nursing home, or in the hospital. Then if they're going to have it administered by one of us, one of the doctors, we can do it in their home, we can do it in a hospital. But just having a little look here about, I guess, what your responsibilities are, and I'm conscious that we've got some doctors on the line, but we've probably got some nurses as well. So if I start with people who are not medical practitioners, you are still able to talk to someone about voluntary assisted dying. In this state, we are allowed to bring up the topic of voluntary assisted dying, as long as we're doing it in the context of end-of-life options. So if we're talking to someone and they're saying, well, what happens, if my cancer gets worse? What happens if my pain's terrible? What happens if I don't want to keep going? We can certainly say things like, well, you can continue with your chemotherapy. You might choose that you've had enough treatment and that you just want control of your symptoms with palliative care medications, or we do now have voluntary assisted dying in New South Wales. However, you can't, if you're not a medical practitioner, take what they call a first request. If you are a medical practitioner, even if you haven't done the training, you are actually allowed to take a first request. If you've not done your training, so you're not what we call an authorised practitioner, you tell them that I take your first request, I hear it, but I can't actually accept it because I haven't done my training. You're supposed to record that in a patient's medical record. And theoretically, you are supposed to upload, you actually have a legal obligation to upload a first request form to the New South Wales Health VAD portal. If you do that, it doesn't go anywhere, doesn't do anything. So whilst I'm saying that's your legal obligation, we've had cases where doctors have been great and they've done that and they think that there's someone on the line there who will receive that as a referral and then go and see the patient. That would be great if it happens, but it's not the way it works. So what I would ask you as the most important thing is if you have a patient who is expressing an interest in voluntary assisted dying, give them this Care Navigator number. This is the number in Western New South Wales. There is also a state-based group of care navigators that have a 1300 number that if you just sort of Google voluntary assisted dying and get onto the New South Wales Health website, you'll probably come up with that 1300 number. That is absolutely fine. The patients will get through to very experienced care navigators who are either nurses, social workers, etc., and they will redirect them to the Western New South Wales number. But this number will mostly get you through to Jade, who's our fantastic health services manager. She is an RN. She's got an amazing amount of experience in this area. And so that's who they'll get to talk to. And as I say, it can just be if they're thinking about it or they just want more information. So just to let you know who's in our team, as I say, we've got Jade, who's the absolute backbone of our team, who does all of our organisation, does all of our booking with patients. She takes all the calls for them. She fills in all those gaps in between our appointments. She also organises everything with the hospitals if we need to sort of bring patients in. I've written there 8 VMOs, which sounds like a lot. And there's probably actually a couple more in the area. The workload varies a lot. We have at least one doctor who's doing 1 to 2 days every week. Sometimes I'm doing that, sometimes I'm not doing any. And then we have a few other doctors who will sort of come in and do a consulting assessment as needed. Sometimes we try to match people up a little bit. Warren, who's going to speak to us later, is a psychiatrist. Sometimes we find he might be well suited to helping us out and seeing a patient. There are some doctors who will only see people in their own town. There are some who at this stage are only an administering practitioner. There are some who do a lot of work in other areas, be it oncology or haematology, who don't wish to be administering practitioners, and that is fine as well. There is a role for nurse practitioners, which is always very interesting out in rural areas, and we do have a nurse practitioner who will work with our service when Jade's away, but not in the full capacity that a nurse practitioner can. Some of the other LHDs do have nurse practitioners who are actually administering practitioners. In terms of governance, we have a meeting, which is essentially our MDT, every Friday, which consists of the VAD team, so those VMOs and Jade. We're really lucky in the palliative care. We usually get Jackie from Dubbo and Louis Christie from Orange. Sometimes we have the oncologist, pharmacy, we have the Aboriginal health workers, and we get sort of rural sector reps. And particularly if we know that we might have an administration coming up at a particular hospital, then we'll get reps from their hospital to come. I would say when I talk about this meeting at other LHDs that we're kind of the envy of the state, that we have such a good team and we have such a good relationship with our palliative care teams. And there's certainly times where we have been able to facilitate the referral to palliative care that may not have come in elsewhere. There's certainly times when we've been able to say we've been and seen someone, we feel like they're struggling in this area, what can help them, and palliative care have been fantastic at making sure they get to that patient early. The other lovely thing is that we have Mark Arnold at that meeting and as one of our VMOs. So you sort of feel extremely well supported when your chief medical officer is on board and in the meetings. And not that we've had particular issues, but there's actually some LHDs where there are conscientious objectors in the administration and they, can be much harder to get things done. But this is also a way that, we make sure that it's known that any administrations coming into the hospital are known about. I've talked a little bit there about palliative care. Can't stress enough that the two of us work together, and we're certainly not, offering a 24-hour service. Palliative care is still very much managing the patients and their symptoms, and certainly people who are working in palliative care, are going to be seeing people who have applied for voluntary assisted dying and might have questions for them. If we just have a little look, this is a nice little graph of what's happened within Western New South Wales. So you can see we're getting about 7 referrals a month. It might not look like many, but there's been a bit of a calculation and we've sort of worked out for every referral that makes it sort of through the full assessment, there's probably about 12 hours of work for a doctor to do that. So it's quite a lot of work with each one. Again, if we have a look, you can see there's been a lot more inquiries that don't go on to have assessments. And that's absolutely fine, and that's what we want. We want people asking, finding out, working out if it's something that they do want to pursue. You can then see that from that first assessment, we've had quite a few that haven't progressed along. They've just stopped at the first assessment. There's a couple of reasons for that. There are people who come to us very late in their illness, and so they actually deteriorate, decline, and will die before they get through the process, or what we call lose capacity. Now, that's not a huge issue because generally they're being well looked after with palliative care. However, if it's something that really matters to them, it can be quite distressing. And it's particularly distressing if they've asked about it early and everybody said, no, don't worry, you're too early for that, don't be pessimistic. And they've then missed out. The other group of people are the people who we go and see. And each visit, we probably spend about an hour, which is the thing I love about this job, is that I actually get time to spend with people. And those of you who work in general practice would understand what I'm talking about. that to actually sit down with someone and talk to them for an hour about their illness, about their background, their family, what they want for their end of life is such a privilege. And so some of them, when we talk to them, they actually realise that it's not what they want, that this isn't sort of something they want, but they're just pleased to have that information. The other thing that we find is we go and see people and they don't actually meet the criteria, which I'll talk about later. So they don't actually qualify for voluntary assisted dying. And that might be that they don't qualify yet, or it might be that they won't qualify. But as you can see, once they get to the consulting assessment, they usually get to the final review. Up till July, we'd had 20 VAD-related deaths. Again, the difference here can be because someone dies before they access it, or we've got people who are approved, but they're not yet ready to access VAD. And I heard a wonderful quote at a conference that I went to where a gentleman spoke to us, and once he got his approval, he said, now that the dying's taken care of, I can get on with living. Just briefly there, just because of the area, we spend a lot of time travelling, and that's just a reality. But the good thing is that we're aware of that, and it is factored into our time. And I think this is a wonderful thing. You can see that most of our visits take place in the home. And when you've got people who are very sick, having to attend a lot of appointments, the luxury of someone coming to them is enormous. Just having a little look here, you can see where we have hospitals, the crosses there, where we have multi-purpose service units. The pins are where we have seen people and have administrations. And I've just put down a list there, which probably needs expanding on now, but is a list of sort of the towns and the places that we have been. Probably finding that more people towards this eastern side are accessing, but we'll sort of see what happens over time with that. So I said that I'd just go back and mention what makes someone eligible. They need to be over 18, live in New South Wales for 12 months. They need to have decision-making capacity, and we're going to spend a little bit of time on that shortly. Their requests must be voluntary, enduring, free from pressure or duress. Fortunately, I haven't encountered this yet where someone is being pressured. If anything, we may encounter people where some of their healthcare workers are trying to tell them not to, or their families not comfortable with their decision. And then if we look at the medical criteria, they must have a progressive, advanced disease, illness, or medical condition that's likely to cause their death in 6 months. Or if we're looking at a neurological or neurodegenerative condition, 12 months. And it has to be causing suffering not able to be relieved in a way the patient finds tolerable. I mentioned earlier that you can bring it up. What I would really ask is that you refer early. You don't have to determine if they meet the criteria. I liken it to if you refer someone to any specialist, if you refer them to a cardiologist, you're not referring them to a cardiologist because you know how to treat their heart disease. You're referring them because you want that expertise. So you don't have to determine what their prognosis is. You don't have to determine if they have capacity. We are happy to do that. We're getting a lot of experience in doing it. And we are getting comfortable with saying to people, you don't qualify yet because they might have a prognosis of 2 years. But you can reapply if things change. You get more unwell, and people sometimes just appreciate having that conversation. The other thing I would say is don't assume that you know someone's suffering. Suffering can be so much more than pain. Pain's the easy one that we know about. Pain we feel like we should be able to fix these days, but we can't always. But for some people, there is a lot more to their suffering. Their loss of independence, their loss of dignity, their fear of dying. And most people that I've come across, they're not fearful of actually being dead, of no longer existing. They're fearful of what will happen in those few days and weeks beforehand. And certainly a big part of our role is explaining to them what is likely to happen. But for some people, they don't consider it tolerable. So what I'd like to do, we don't have any questions at the moment, is just present a couple of cases to you. What I've done with these cases is they're a bit of an amalgamation of things that I have seen, not necessarily Western. I've probably drawn them more from my travels around the state, and kind of put a few issues into one, but what we do come up with. So I'll present the two cases, and then I'm going to hand over to Warren to have a bit of a chat about the issues and particularly around capacity that are raised in this. So if we have a look at our first case, 79-year-old Giuseppe Bianco, he lives with his daughter. He had been independent with his ADLs, but very, very slow, but he sort of had all day. His wife had died from AML. He'd watched her die, and she'd spent the last 3 weeks of her life in hospital, and their family had found that a very distressing experience. He has COPD, he is on oxygen, he's losing weight, he has had a hospital admission where he required BiPAP. When he was in hospital, after he came off with his BiPAP, they did do an MSE, which he scored 22 out of 30, so he's now been labelled as having cognitive impairment. About 2 weeks ago, he fractured his wrist, so he needs help now with all his ADLs. He has 4 brothers, and the last of them died last week. So he's feeling quite distressed. Said he's had enough, wants it to be over. He's heard about voluntary assisted dying and thinks that that's the thing for him. And then we've got Maria Sargent, who's a lady with metastatic breast cancer. There's no further active treatment available for her. She has mets to her bone and brain. She's got a lot of pain, so she's on a syringe driver for the past 5 days, and it's having quite a good effect. Because of her brain mets, she does have a little bit of word-finding difficulties. She is on dexamethasone for this. She's actually already had her approval for a couple of months for VAD, but she doesn't want it yet. She definitely wants it, but she wants to wait because her son's coming from Canada on the weekend. So I'll hand over to you, Warren, to chat about this.
Thanks very much for excellent presentation so far, Catherine. I'm a little bit biased, but I thought that was really good. Hi, I'm Warren Keeley-Bateman. So I'm part of the VAD team, and my background is in psychiatry as well. Decision-making capacity is really important in VAD, and it's one of the questions we commonly get asked by people that we go and see. VAD is not part of an advanced care directive. You can't decide to have VAD and then for us to come along and later administer VAD to you. You need to be in a really clear sensorium when you actually continue through this process and you actually decide to have voluntary assisted dying. So this is something that we don't do to people, we do with people throughout this whole process. So what constitutes consent for VAD? And that's really important. And I might come back to these two cases in a minute and have a look at them. So when does a patient lose capacity, and what's it like if they can't communicate their wishes or if they're on a syringe driver? So That's all right. You can get going with the slides. That's okay. Capacity, Catherine's going to drive the slides. We thought it was too hard for us to juggle PowerPoints. Capacity refers to a person's ability to understand, appreciate, reason, and make informed decisions. And this is in line with international legal and medical frameworks that globally emphasise that we need to get this right in the BAD process. So right around Australia and New Zealand and around much of the Western world, we're really working in step. Can I have the next slide, please, Catherine? So drilling that down, there's some core principles. People need to understand, so they need to comprehend the nature and the consequences of the decision. They need some retention and the ability for the information to remain there regarding their decision. They need to be able to weigh up that information and deliberate on the options and consequences. So we'll commonly ask people, what are the other treatments that they're having, etc. And as you've heard from Catherine, people are often in a frame of care that is not just about BAD, it's about a whole range of other care from health services around them, including usually palliative care as well. And that they need to communicate with us and express their wishes. Now, of course, if people have got neurodegenerative conditions, if they've had strokes, if they're elderly, if they've got levels of dementia or cognitive decline, they're going to have difficulties communicating with us. They might even have difficulties expressing that and need people to sign for them. But we can often navigate our way around that, and people can communicate with us. And a lot of us are used to dealing with patients who express their communication in different ways, so that can be worked around. Can I have the next slide, please? Now, common things that we confront in hospital, most of us have trained in hospital at some point, are things like the triple Ds, depression, dementia, and delirium. So we need to kind of exclude or think about those mediating people's decision to capacity to make decisions and their capacity assessment. So I like being on part of the team because I can kind of zoom in there and think really quickly if someone's got a mental illness, particularly things like depression and anxiety, which can leave people quite impaired. Things like neurodegenerative disorders like dementia, things like delirium, and many of our patients that we see in hospital are often confused, and they might be confused for quite simple reasons, and that might actually resolve simple things like UTIs and constipation, etc. And we can certainly circle back and look at them again if there are simple things like that that should be dealt with, and then we can exclude those. But there are also cultural and contextual factors that may mean there's a bridge that we need to build to make sure that we understand why someone may not be able to communicate with us effectively. One of the things I really like that Catherine highlighted is that because this process is so important, we actually stop and we actually sit and we see the patient and we see them really well in the context of their lives. And I know for some of the patients I've seen, they're really approaching the end of their life. And so you think about that psychological stage of Erickson, where we're thinking about people in that stage and that last struggle of ego integrity versus despair. And everyone that I've seen in this process so far is at that point of reflecting on their life. And as I ask about their roles, their relationships, their families, and they tell me their story, that actually often unlocks whether or not they have capacity, because as they build up that frame and that story, I actually know that they're making appropriate linkages, that they're oriented, and they actually know that they're making a decision that's very reasonable for them, and then they go on to express that. And certainly in the recent few months, when someone was able to map out all their great-grandchildren, all their grandchildren, and the history of their life with their partner, I was very, very sure that the person was making a decision with great agency, and really with great beauty, even though it could kind of surprise their family. But this beautiful person had brought their family on board, and I was very humbled to be a part of that process. And I was also very pleased that we have this process available for people. In that context, I might throw back to you, Catherine. Although, sorry, I should look at those cases quickly. Can we just go back to Giuseppe's case quickly for a second? So Giuseppe Bianco, now, Catherine, you wrote those cases, so maybe I'll just quickly discuss those cases. So Giuseppe is 79. He's possibly from a different cultural background, given his brothers all died in Italy last week. He has got some cognitive impairment, but certainly not enough that would exclude him from telling us what he wants on most days. And who knows if that cognitive impairment was scored when he might have been a bit unwell. So I'd want to go back and rescore it as well. I mean, he's got some COPD. I don't know how bad that is, but I'd certainly hope that he was referred to us so we could consider it, and think about where he's at. And I'd love to have a talk to him, but I don't know where this process is going to go at the moment, because I think we need a lot more information. So, I'm really happy to actually see Giuseppe and see what we do with him. But there's not a lot of information about what the outcome would be here at the moment. But he'd be someone that would be referred to us. Did you have any thoughts when you were writing this case?
Yeah, look, you've covered most of them. Very much that thing about the MMSE when it's done, in what might not be someone's first language, when they're sick in hospital. Often people have got masks on. There's a whole lot of factors, and we often find that someone's been labelled as cognitive impairment, not having capacity, and then we go and spend time with them, and they do. I guess my concerns, for this man, we don't know with his COPD, but we can chase that up, and respiratory is one of the hard ones. It's not got that linear course. But I would also be concerned that he's acutely distressed because of his injury and because his brother died. But exactly what you said, Warren, I would hope he would be referred, that someone wouldn't say to this man, oh, no, you're just depressed because you wait till your arm's better, or etc., that he'd be allowed to explore something that might be important to him.
Yeah, I was talking to one of the medical students this afternoon, one of my very talented medical students, and we looked at the CanMeds domains from Canada. And I think one of the important parts of being a professional is being an advocate for the patient. And I think this is an important component of advocacy. So I do agree with you. You don't know where this is going to go. I think Mark's got his hand up. Professor Mark.
Yeah, apparently I've actually become a bit gender fluid at the moment, but it's because Jade had to send me the linkage to get on. But thanks. I think you've summarised the case really well. But there's a couple of other things. I mean, what we say in clinical ethics is, if it's good medicine, it's good ethics, and if it's bad medicine, bad ethics, and so on and so forth. I mean, I guess the thing is, per the criteria, I mean, Giuseppe may well, in fact, meet the criteria. However, we need a bit more medical information about the degree of his COPD, which would appear to be the main driver of his prognosis. And in fact, very recently, we've seen someone who was in exactly this situation. Their suffering was driven by their extraordinary breathlessness. They could barely complete a sentence, so the consultation was quite difficult. The other aspect that I think we also need to cover is that the request for voluntary assisted dying needs to be a clear, unambiguous, and enduring request. And sometimes when we have these hypotheticals, and when someone says to you, well, I've had enough, or I just want this to be over, I mean, I think that's when the nuance in understanding capacity can really come out, because, well, Giuseppe, please explain to me, what is it that you want over, and what is it that you've had enough of? I mean, I can make some guesses, but I'd like you to tell me And what is it that you've actually heard about voluntary assisted dying? So I think that discussion will also really very clearly highlight whether someone does actually have capacity too.
Thanks, Mark. Can we just look at the other case?
Yeah. So Maria.
Yeah. So Maria's progressed down this process, and she has approval for VAD, but she's now on a syringe driver. What did you want to highlight in this case, Catherine?
Yeah, so I guess it brings up the question, and we did have this in a situation where there was a question made about someone's capacity, knowing that they were on medication, in that case probably morphine and midazolam, and some in a treating team had felt that that meant someone automatically didn't have capacity.
Well, we could go and talk to her and find out. I've seen lots of patients on morphine and benzodiazepines who perfectly have capacity over the years. I mean, if there are high doses, maybe not, but we don't know. That's not revealed in this information.
And I guess the other thing, so we might find she has capacity now, but she wants to wait. And I guess what we would tell her about that and what might happen with her capacity.
Yes, yeah. Okay, well, I'm going to throw it back to you, Catherine. Yeah. Thank you.
Yeah, so we might be concerned for this lady that if she does wait till her son arrives, that she declines further, that her medication doses may need to be more for her metastases. She may lose capacity, and in that situation, even though we knew exactly what she wanted and her family might be telling her what she wanted, we would not be able to proceed. But again, that she would continue to receive her palliative care. So I just want to talk a little bit here, and I can answer questions on this, but your role as a treating health professional, and this is regardless of your views, personal views on voluntary assisted dying, your role is to continue all the regular care that you would give, to respect and, as far as you're able, support an individual's choices. And if you're a doctor, there might be a situation, particularly if someone's having oral self-administered medication, where you'll be required to do the end-of-life paperwork. It's our practice, with the patient's consent, that we notify a patient's GP of when a person has completed the VAD process. And if there's anything that we think we'd like you to do, such as the expected death at home form, etc., we will talk to you about that and explain it. The other thing that we'd ask that you do, and that you will find you doing, is providing grief support to family. And it may be because of the patient's wishes that might be the first time you find out, or it may be that you're a treating health professional to a family member, but not to the person who's taken, who's had voluntary assisted dying. So it's just that awareness that you may come in contact with it, and just being comfortable, not acting surprised, and providing your grief support that you always do, which is letting an individual tell you about their experience and what it was for them. So I'm going to throw open to questions, and I've got that slide there, but I'm actually going to bring up, while we talk and see if we've got any questions, I'm going to go back to one of my earlier slides.
So we have got one question. So the question in the chat is, what if their suffering seems to be because they have declined palliative care services?
Yeah.
I think that's a pretty fair question.
Yep, I think that's a very fair question. So everybody has a right to choose what treatment is tolerable to them and what treatment they wish. So they have a right to decline chemotherapy. If they have a neurodegenerative disease, they have a right to decline a PEG tube. They have a right to decline palliative care. However, what I would say is still remains a lot of misunderstanding about palliative care in the community and what it is. And ironically enough, when we come and assess someone for voluntary assisted dying, they didn't want palliative care because they think palliative care will kill them, which seems ironic when they're asking to speak to us. So we do often spend a lot of time explaining what palliative care is, what they can provide in terms of support, equipment, symptom relief. And a lot of people have got their image of palliative care from when their mother, was on a ward for 2 weeks and couldn't get enough pain relief sort of 30 years ago. So sometimes we can help, however, they have every right to decline palliative care, and that if that is their choice and they fit all the other criteria, absolutely they're eligible.
There was also a question, Catherine, what will be the exact role of the coordinating practitioner?
Yeah. Oh, I'm missing one of my slides there. I just realised about training. So the role of the coordinating practitioner is they are the person who takes the first request and does a first assessment. Then there's a second doctor that comes in and does the consulting. Then it's usually back to that first doctor who's called the coordinating practitioner to do the final assessment, to do the administration decision. It is then usually the coordinating practitioner that prescribes the medication, and it's usually the coordinating practitioner that administers the medication. So saying, there are ways that you can transfer the role. So there are times where I might have done the first assessment, a second doctor's done the consulting assessment, I've done that third assessment, but then I'm not available. I've gone on holidays or something when the patient wants to have their medication. I can transfer that role and someone else can give them the medication. It is absolutely ideal to have the same person following them through, but with my work with the Access Service, because of the way we work, we've actually had someone who's had a different doctor sort of along the process at sort of 4 different stages, which is not ideal, but that does happen. So I was supposed to have another slide about potential training, so I'll see if I can find that, because we would love to have more authorised practitioners in the area. As I say, we are spending a lot of time travelling. To become an authorised practitioner, you need to do either an online course, which you can find on the RACGP website, or if someone wants it, I can send a link to that. That is a course that takes about 4 to 6 hours or so to do. And then there's another component about medications that get sent to you. Or you can do a face-to-face, which, if I have to say, and the feedback's been that the face-to-face course is much better, where it's basically a day of having that education of what to do, being educated about the medication. And there are courses coming up. There's one in Queanbeyan on the 15th of September and one in Sydney on the 19th of October. They're both Saturdays. I'll send that information to Jade, or you can contact me or contact Katie or Ali at the PHN, and we will get that information to you. Those courses are free. There's no cost to you. New South Wales Health covers the cost. There isn't any accommodation or transport, but most of you, if you're in a rural area, could apply through the RDN for a scholarship to cover some of those costs. I'll try and find that slide. So a couple more questions there. Do we ever suspect a request is triggered by family pressure, elder abuse? We worried a lot about that, and my experience so far has been no. We almost find the opposite, that families don't want people to access and pressure them out of it. There's certainly situations where, as you would all know, as someone gets older, they often stop being told about their health. Often if they're a bit deaf, the English isn't their first language, a relative does start to answer for them. And so we have techniques that we use, and we often go on these visits with two people. And, you know, like I might take Jade with me, and I would get Jade to take the daughter out of the room. So I'm only speaking to the person to, you know, to assess for that. Did I see another question there? Will a general practitioner be asked to prescribe or administer? Absolutely not. This is very much something that you choose to do, and you must do the training to become an authorised practitioner. We have authorised practitioners who feel very comfortable assessing someone, but will never feel comfortable administering medication, and that's absolutely fine. They can just take that role. But unless you've chosen to work in voluntary assisted dying and become an authorised practitioner, no, you won't be.
Catherine, I just put a little link in the chat. It's just if anyone wants to register to find out a little bit more about the VAD training, you can leave your details and I'll get back in contact with you.
Thank you. I'm going looking for my missing slide about training, but no, that one got lost somewhere. Just while we're waiting, or if there's any more questions, I just came back to this slide. We do have permission to use this photo. This is actually a photo taken at one of our administrations. And so that's each of the 4 family members' hands. And it was one of the most beautiful deaths that I have had the privilege to be involved in. No more questions?